are part of an ongoing effort to engage measure developers and other stakeholders in quality measurement topics. That's an effort that also includes a series of newsletters and bulletins, along with special announcement emails, public webinars, and routine updates to the Measures Management System website. We are happy to report that we are now doing these info sessions on a monthly basis as opposed to bi-monthly, so that we can continue to provide up-to-date information on a wide range of topics related to quality measure development. And at the end of today's call, we'll talk about some of the ones that are upcoming. So before we jump into the presentation, I just want to cover a handful of housekeeping items. The first is that today's session is being recorded. The second is that all participants are going to be muted during the call. We are going to have an opportunity for Q&A at the end. However, we're going to do this via the chat feature in WebEx to avoid issues with folks not muting their lines. So we encourage you to enter your questions in the chat feature. As you think of them, you can save them for the end or include them in the chat during the presentation, and then we'll queue them in order. And then finally, the presentation slides from today's session are going to be posted on the MMS website. And then the recording of today's presentation is going to be posted on the CMS YouTube page at a later date. And with that, we can go to the next slide, and I'm going to hand it over to Ellen Schultz.
All right, thank you so much. It's really a pleasure to be here with you all today. I'm Ellen Schultz. I'm a senior researcher at the American Institute for Research, where my work focuses on measurement, and in particular on engaging patients, caregivers, and communities in measurement as a strategy for reorienting our systems towards people. I want to thank you for the invitation to be here today and talk about what our team has learned about making measurement patient-centered. When we talk about measurement that's patient-centered, we mean measurement that's driven by patients' expressed needs, not assumptions about what matters to them. We mean measurement that makes a difference for and ultimately benefits patients, and that means focusing on the structures, processes, and especially the outcomes that patients care about, not what the system thinks that they should care about. A couple things I just want to say up front before going any further. First of all, I'm using the term patient here as a shorthand for people who are seeking care or services to help support their health and well-being. Within a healthcare context, we think about patients, also thinking about caregivers, whether they be family members or other friends or informal support network. And in a broader context, particularly as healthcare is thinking about recognizing and addressing social determinants of health, we have to think about communities, or in some contexts, we think about, clients. So, patients is very much a shorthand, but thinking about all of those who bring lived experience seeking care and services to support their health and well-being. The other thing I want to say right up front is that this idea of patient-centered measurement is not limited just to particular topics or areas of focus or even types of measures. So I'm not talking only about patient-reported measures, such as patient-reported outcome measures or patient experience of care measures, such as CAPS. I'm not talking only about measures of patient-centeredness of care, so certainly those would be included. This is something much broader, thinking about whatever we're measuring and why and how we're using that measurement. We have to make sure that we're focusing on what really matters to people that affects their health and their well-being in their lives. And finally, I'm being really intentional here in talking about measurement, not just measures. And that's because it's important to focus not just on what we're measuring, so the individual metrics or indicators, but also how are we measuring? What data are we using? Where do those data come from? How are they collected? Who controls the data and ultimately owns them? How are we reporting out that information? What are the ways that we are aggregating it or disaggregating it? For example, are we, breaking down measure results by race, ethnicity, language, or other demographic factors? And then ultimately, we have to look at how are we using measurement? Like, how is this information ultimately guiding decisions and policies and care within healthcare systems in a way that ultimately improves lives? So we can go on to the next slide, please. To lay out a vision for what measurement looks like when it's patient-centered, several years ago, AIR brought together a diverse group of stakeholders. This included many patients, caregivers, and patient advocates as well as researchers, clinicians, measure developers, policymakers, and payers. And we asked them, what does measurement look like when it's patient-centered? And their answers, we were able to really boil down into these 5 principles. And these are the foundation for the rest of what we'll talk about today, so I want to touch on each of them individually. First of all, measurement is patient-centered when it's patient-driven. This means that patients' experiences, needs, goals, and values, as expressed by patients themselves, are at the heart of what we measure and how we use measurement. Measurement is patient-centered when it's holistic, meaning that it considers the whole person, their journeys over time and across care settings, and really recognizes patients as people with lives not only intersecting with healthcare systems, but especially recognizing their lives outside of healthcare. Measurement is patient-centered when it's transparent, meaning that information is shared in ways that patients can understand and use. They have access to the same information as other stakeholders. And maybe most importantly, they're able to understand how measurement is used, whether to guide the care that we provide at an individual level, or thinking about accountability and payment and our healthcare policy. A lot of the ways in which measurement is highly influential in healthcare are not currently transparent to everyday people, and it's important that we get to that place. Measurement is patient-centered when it's comprehensible and timely. This means that patients, as well as other stakeholders, have access to information that they can understand, interpret, and use at the time that it is needed. And finally, measurement is patient-centered when it's co-created with patients as equal partners. This means that patients have a clear role, early and ongoing involvement, and shared power and responsibility for decision-making. Next slide, please. So we then wanted to see how these principles will play out in practice. And so with support from the Robert Wood Johnson Foundation, AIR put out a call for small-scale pilot projects. We got an overwhelming response with more than 75 applications received, and we ultimately, through a competitive review process, selected 4 to fund. For the record, we would have really liked to have funded more than 4, but that was what we had the resources for. Each of these projects was about 18 months in duration and received just under $200,000 in funding, so they were quite small. 3 of them focused on measure development, and the 4th on implementing 2 existing measures. They focused on very different patient populations and care journeys, ranging from maternity care to cancer care, rehabilitation after traumatic brain injury, and dialysis. One of the projects was led by a patient advocacy organization, and the other 3 were led by teams of university-based researchers. All of these pilots had at least one patient or caregiver as team members, and most of them had multiple patients on their team. They all used different models of what that team structure looked like and what their roles were for the patients on their team. So there are many, many different ways of doing this work, but they all made sure that that lived experience was embedded within the core team doing the work. One of the pilots was actually led by a patient, or co-led by a patient. We're fortunate to have him here with us today, and so I'll be handing things over to Derek Forfang in just a moment to speak about his experience. But before I do that, I want to touch on what I think are 2 of the most important lessons that we learned from observing and coming together on a learning journey with these pilots. The first is that co-creation through equal partnerships among researchers, clinicians, patients, and caregivers are really the foundation of patient-centered measurement. These teams told us that co-creation means building partnerships where there's shared decision-making within the team about how the project is conducted, and that patient and caregiver partners' voices had equal weight among team members. They talked about coming to mutual agreement and how their roles were determined and carried out, including checking in over time and making adjustments to those roles when something wasn't quite working or when there was even more that they could do. These teams told us again and again how important these partnerships were to their work. And we saw that when co-creation is happening, the other principles tended to fall into place. So for example, the pilot that focused on cancer care heard early on from their patient-led steering committee that they needed to broaden their scope to include a wider range of cancer journeys. And that meant broadening who was included on the steering committee. So that team invited additional members. into the committee, and they broadened out the scope of cancer experiences that they were trying to capture through measurement. By working in partnership between the core team and the steering committee of ultimately 10 patients, this pilot was able to make their work more holistic. And they did that by making their team more holistic too, broadening out the diversity of perspectives within their team. The second really important lesson that stands out to me from this work is that patient-centered measurement requires a combination of commitment to patient-centeredness and flexibility. That example I just shared from the cancer-focused pilot is another good example of this too. They were committed enough to being patient-centered, to listening to, acting on, and partnering with their committee of patients, that they were willing to be flexible in their approach, even when it meant changing their plans, or in this case, some of the focus and the scope of the project. We saw this combination of commitment to patient-centeredness and flexibility was important at multiple levels. Certainly within these pilot teams, it was also important within the organizations where their work was happening, and they told us that it was important from us as the funder. We learned to be flexible and show our commitment in our role as the funder. We learned to see adjustments to scope and timeline as progress rather than viewing it as a step backwards. And we learned to be willing to pay for things that we might not normally do in a project like this, such as purchasing laptops for caregiver partners who were running into technology hurdles that were getting in the way of their contributions to the project. So by being flexible and at the same time making our commitment clear, by modeling equal partnerships among patients, researchers, and measure developers within our own team, and showing what that looks like and how we were bringing these pilots together in a learning community, we made it possible for them to put these principles into practice. So now here to tell us a little bit more about what patient-centered measurement looks like in practice, I'm joined today by Derek Forfang. He's a tireless advocate for patient-centered kidney care, and he himself has experienced dialysis and kidney transplant. He co-led one of these 4 pilot projects with Dr. Jenny Fly from the University of North Carolina at Chapel Hill. And he's going to share with us some of how his team has worked together and what they learned along the way and how to bring these principles to life. So Derek, I'll hand it off to you. Thank you.
Terrific. Thank you, Ellen. So starting with this project, this is really an opportunity that I had found for this for the funding for this project to happen. And I actually realized I don't have dialysis centers myself, but I had a vision that tied into the principles that AIR had put forward. So I reached out to nephrologist, Dr. Jenny Fly from the University of North Carolina, and asked her if the university would be interested in working on this together. And she basically came back to me, and the university had said that they would be willing to work with me if I had 50% decision-making on all aspects of the project, which was unique from the start. Never been approached like that before. So we started with the project, and I was involved in all aspects, from the budget to selecting providers, selecting patients for our project team, talking about the vision of where we were going, kind of molding that, looking at all aspects of the process. So it was really exciting for me. I've been on TEPS and done various things around measures for about the last 7 or 8 years, and but only had been in little pieces and parts of the measurement process. So this was really a chance to go from creation all the way to implementation. So it was a really fantastic opportunity, and I learned very much from it. So the focus of the project was really to look at delivering care in a different way and improving care in a dialysis facility. The focus is really on patient life goals, even though the word goals brought patients right away to focus on clinical goals. But what we're talking about is what's really important to patients in their lives, maybe what was important to people before they were on dialysis that they had to stop. So whether they had a hobby of doing gardening, or whether they like to travel or spend time with family, or if they had requirements to go to work, go to school, take care of elderly parents or young children, and really talk about what their needs were and wants and desires were, and then build their treatment around it, rather than focus on these care meetings on really check-the-box clinical areas, but make it more meaningful to patients. And my hope is that would really improve patient engagement, patient adherence to medications and treatment, and things that are around dialysis, and really create a more hopeful atmosphere. Through my 12 years on dialysis, I was in many clinics, and I would see patients just struggling, both physically and emotionally. And much of what their life looked like before had disappeared, and their focus was on just having their treatment done. And I've talked in the past about, for me personally, dialysis was kidney disease in general was a disease of losses in the beginning, and it's a focus of, loss of your career, loss of, your freedom in many ways, and certain loss in even your relationships, what you're able to do as a parent or a spouse, or many of those things change. So it was a very tough thing to get into. And then as far as your treatments goes, you're in the center 4 hours, 3 times a week. Your life's really centered around that, and you can lose yourself. So the vision was to really gain your identity back as a person and make the treatment flexible to really support what you want to do. And so we looked at how we would do that, and some things we did in the very beginning of the project were really, everything we did was very intentional. We wanted to have diversity in the project. We felt it was important that sort of who we had engaged and all the research that we did, that the patients looked like the majority of people that had kidney failure. People of color, African Americans have a 3 to 4 greater chance of having kidney failure. And also the Hispanic community has twice the greater chance of experiencing kidney failure than white patients. So anyway, we looked at on a national basis, and there's a picture here of our project team, and we hand-selected and reached out to people. We had patients that had some national experience. We had a patient who was a caregiver as well for his mother who had kidney issues. We had a local patient who had never been in a project before, which I thought was very important. And then we also had providers that had different experiences from different areas, as well as a social worker. So we moved forward with the project. One of the first things I did is actually took ethics training. I really wanted to be involved with talking to patients myself. A big part of what we did is we wanted to make sure that this was patient-driven, not just by me as a patient, but the whole process was driven by patient feedback, trying to understand what was meaningful and most meaningful. How do we communicate? Like I said, we used the word goals. Well, it didn't work. And we finally found that it was better to say, what matters to you most? And patients understood that a little better than the word goals. So we learned a lot. We went out and we actually, I don't think in measurement sometimes, you're involved in a TEP, but you don't really experience what the measurement's about, and you may get the same group of people over and over again. We wanted to make sure we got people that would be most effective by this this project and the measures that we put in place. So we went to the dialysis centers ourselves, and we interviewed patients, and we would get all our materials vetted through that process and come back to the project team and make decisions. So, like I said, everything we did was very intentional. We wanted to make sure the people we talked to were diverse, and so we got multiple opinions, and not only on the project itself, which changed some of what our thoughts were in the beginning on how to make sure, this was approached in the right way, that and that the measures really made sense to people and would actually lead to what we were trying to change, which is really a change of culture in the dialysis facility. So through that, if you'll change to the next slide, we looked at an individual metric and measures that would sort of measure what was going on. And the first question, my dialysis teams make me feel like my voice is important. And to show really that you feel empowered, there's shared decision-making going on. Currently, in the dialysis facility, we have the CAP survey, but it's really not specific and really doesn't show patient satisfaction in the way that we felt we needed to understand from patients. So the second question we got into was the understand what matters to me. And that ties back to what I was talking about as far as life goals and what's important to us as people. And the third one was care team consider important parts of my life. And I already had touched on that. And we found through this, when it got to the clinic and we had these discussions, and this is a CMS required meeting that happens annually or quarterly if the patient's not stable, but it's an annual meeting, has the whole care team there. And normally, like I said, we took out a form and checked boxes, and this started with just talking about the patient and what they're going through and what's important to them and what's happening in their life. And they found at the dialysis center, they learned a lot. Things that normally just didn't come up. They learned that a particular patient was homeless, and they didn't know that. And they were able, through talking about that issue, it really satisfied the team that was involved. The social worker got to use skills they don't normally use in the dialysis facility, actually was able to start to look for a place that he could live. And so the whole team kicked into action. And we found this over and over where things came up. People had needed a driver's license and had issues on taking a past medication they didn't even take anymore that caused them to lose their driving privilege, and able to give them back a license. Things, they started a lady who used to love to garden, who really needed just some physical therapy and some additional tools, talked to the family, brought them in, got her a referral for physical therapy, and it just changed the way she was doing things. Many times you look at a goal, a personal life goal, like you want to watch your grandson graduate from college, and then it creates a different conversation as far as what the patient's accountable for and what the care team can do to keep you healthy, to get you to physical therapy if that's something you need to do. And then all of a sudden the patient is more engaged, and they know they want to go ahead and take their medications. They want to make it to their treatments so they can make it to this life goal that they have, which is important to them, rather than just go in for treatments because they're told to and do these things because they're harped on during treatment. So really changed the way that patients were engaged. So my dialysis care matches my priorities, looking at individual partnership. And lastly, my dialysis team and I work together to make decisions. We need to make sure that the decisions are focused on, what the meaningful to the patient, but also, what is realistic. We want to make sure that these things are attainable and that there was follow-up, within the first month or so to see, are we moving towards that direction? Have things been put in place? A list of responsibilities from, what the patient's accountable for, but also what the social worker maybe took on action items during that meeting. So we found through this process that people started to have better experience with their care. Patients actually became emotional, feeling like they hadn't felt that people cared for them in this manner. So we had many patients actually broke down during these sessions of care planning, and we really ended up getting a lot of success from what we did from this vision. Although it was different, we went back and had to vet things through this process and make changes. These measures changed over time through the project. We changed the way they read to make sure they were understood by all. We also had developed some written materials, and the written materials helped the patient understand how this meeting was different, how to prepare themselves to get into the meeting. Also on the provider side, how these meetings were different and what they needed to do and think about before they sat in there. It wasn't for them to talk and a patient to listen. It was for a patient to talk and the provider to listen and then have a meaningful discussion. So we found these measures worked, and I think the biggest learning lesson that I'd like to share is that you can't keep doing things the same way and wanting to get different results. And so sometimes you need to go to where the patients are. Some of these patients wouldn't be able to travel. They might not have the ability to be on a Zoom meeting or be on the computer. So we had to go to them. And I think that's what made all the difference in this process. And I think the other piece was really being intentional on diversity, making sure we got all voices that were part of the process and get patients to really be able to have the time to speak to us in an honest way. I think many times we noticed the difference when I was in the room versus just our project assistant is patients opened up differently to talk to a fellow patient. We understood each other, and you could tell that right away. And sometimes they would be a little more open and honest. So I think really having things sort of patient-driven and co-created and having patients engaged, not just myself, but the whole team in various steps through the measurement process, not just at the end to do a rubber stamp or to get some feedback to polish things up, but really talk about what's meaningful in the beginning. I was very involved with the Meaningful Measures project that CMS had done, and I felt very committed to that because I feel like many times we have a measure, but it's hard for patients to get behind if they don't understand it or don't feel like it really impacts their life. So I think there's better ways we can do things, and so I encourage you to look at this. We're actually going to have a manuscript published very soon, and we'll get that out. You can find all this information on the University of North Carolina website under their kidney. Actually, if you look at my dialysis plan, if you Google that to UNC, it'll bring you right to the site, and you can see all our information there. So with that, I appreciate this opportunity to speak, and I will turn it over to Knitasha.
Thank you so much, Derek, and thank you to Ellen. If we could advance to the next slide, please. As my colleagues shared before me, this work that has been done in patient-centered measurement is work that has been going on for about the last 5-6 years or so. But coming into the year 2020, I think there has been a huge amount of evidence around just a shift in many industries in terms of looking at equity in a different way, and much of that has been causation from, one, COVID-19, and just the level of transparency, right, that was demonstrated in the news by many state departments showing their COVID results and stratifying those results by race and ethnicity, therefore exposing to the world the huge gaps that we had in terms of what we were seeing within subpopulations. And then as we were, matriculating along, this COVID-19 journey, there came the death of George Floyd in the springtime, and that really resonated with Americans in terms of the sense of urgency around structural racism and what that looks like, again, across many industries, including healthcare. And so as these two, if you will, dynamics were occurring, my colleagues at AIR reached out to say, we've been doing this work in patient-centered measurement. We know it's the right work, but quite honestly, we haven't taken a very meaningful look at what that means from an equitable standpoint. And that we really would like to take a step back and begin to look at where there might be opportunities for us to make this work more equitable. And I can tell you that as I introduce to you this new body of work, which is continues to emerge, that I have heard, from peers and from colleagues that this is the ideal time to be disruptive of the work and progress toward patient-centered measurement as it relates to equity. So allow me to introduce you to equity and patient-centered measurement. This is a project that we actually just got started back in, actually it's around November. And the objective of this, again, is to look at the way in which we develop, select, implement, and measure this work in terms of equal partnerships and diversity of patients and families as it relates to measurement, and also looking at how might we shift the power in measurement more towards community, thereby making it more equitable. So the work that ATW Health Solutions has been charged with is actually a two-part. One, we have been working on an environmental scan, and that's to really help us understand the perspectives of leaders in the healthcare space, leaders in measures development, leaders of organizations like CMS, NQF, AHRQ, HRSA, you name it, and patients and families. So to understand, what the perspectives of individuals in this work and that are doing this work, what is their take on equity within the space of patient-centered measurement, recognizing that we haven't fully implemented patient-centered measurement. And then the second part of it is for us to develop a theory of change. And so what we've done thus far in the work is that, first I should say that this body of work should be completed in May of this year, May 2021. And so what I'm introducing to you today is actually some of our preliminary results as we continue to compile data and analyze the data that we have. If you can go to the next slide, two of the primary research questions that we have of the 58 plus interviews that we've completed, there are two primary questions. One, the question is around how do we make the practice of patient-centered measurement more equitable? And then the second question is what is the path to shifting the power of measurement away from the entrenched interests within healthcare and towards patients, families, and their communities. And let me say this: there's two concepts or two key insights I think that's most important to understand as it relates to why equity is important in this conversation of patient-centered measurement. And first, it's fairly simple, and I think Derek began to approach it. And that's this one-size-fits-all approach we have, right? So we have kind of this one-size-fits-all approach to measurement. And quite honestly, it's no longer working in this largely diverse and changing environment, and that is clear from what we see in terms of health disparities in the numbers. And then secondly, that it's not just about adding patients, meaning physical bodies or people, to the process, but it's also about developing meaningful relationships that bring value so that they shape the way in which the work is done, the way agendas are established, the way the work is evaluated. So hear me when I make the distinction between the two. Oftentimes when we talk about diversity and patient-centered measurement, say, oh, well, we're gonna make certain that we add, a diverse panel of people. Well, yes, that's one step. But the second step is that we have to make certain that we are doing it in a way that is driving meaningful partnerships, whereas it's literally shifting the culture of the way in which we deliver care and the way in which we measure. So in this work, it's important to understand that the opportunity is not just singularly in adding more diverse people, but it's also about making certain that we have a diverse panel of researchers at the table, right? So that we have Black researchers like myself and others who actually work in the space, understand the space from a measurement standpoint, and are thereby able to shape agendas, because that's where you begin to actually shift the power. What we have to recognize is that when we talk about, whether it's patient engagement or we talk about patient-centered measurement, we talk about making certain that there's this inclusion of values, beliefs, and experiences, right? Well, the fact of the matter is, and this goes back to the one-size or the lack of the one-size-fits-all approach, is that culture shapes our values, beliefs, and experiences. And culture is very much shaped by race and ethnicity. And so what we have to do is not only make certain that we're adding a diverse panel of patients and families to the conversation, but we are also making certain that there is diversity throughout the process and throughout our systems, and that we have measures of accountability. Now, let me talk a little bit about that. Here, what you have on the slide, you got in terms of the, let's say, the primary themes that are emerging, from the conversations that we've been having: measurement architecture, pockets of excellence, diversity and inclusion, funding priorities, and community empowerment and transparency. And what I can say in this work is that what we've learned from people is that it's, a lot of this is not just what we know should be done, but the fact that many people are not getting paid to do this type of work. So we've heard this from measures developers, like, we know this is the right thing to do, but quite honestly, nobody's paying for this. And then the other big piece that we heard as it relates to measurement, architecture, and design is that there has to be accountability in this, meaning that everyone knows we need to drive more equity in the process. We need to add more diverse patients. We need to make certain that there are more diverse researchers. We need to, make certain that these voices are integrated throughout all facets of the work, throughout the continuum in the ecosystem of healthcare delivery. Yet, there aren't any tools and or resources to help support us in doing that, Knitasha. So when, and by virtue of example, is that, when a funder is identifying an opportunity in setting and establishing that agenda and who we're selecting to fund, are we actually looking at the diversity of those that we fund, and whether or not who they have as their panel of constituents that will be doing the work actually look like the individuals that we're working with in partnership in the communities. And so again, there has been a huge emphasis on this need for accountability. Pockets of excellence. So there has been many conversations, whether it be from our funder leaders, whether it be from constituents in the community, or whether it be patients. We have heard about these pockets of excellence, meaning this work has been going on, yet it has not been widely disseminated. So we need to really go back and establish what do we have in our repertoire that can very easily be disseminated so that more widespread gets more individuals, more people, more measures developers activated in this work. And even in doing that, one of the areas of opportunities is actually look at developing some sense of guide, or a sort of guide or a roadmap, if you will, that creates an evidence-based approach to quality measurement framework and addresses equity and patient-centered measurement within that work as well. So we have not only this measurement architecture and design opportunities, but definitely there's an opportunity to take what we know and understand and to make certain that that is more widely disseminated. Diversity and inclusion, I believe that I have touched upon that pretty greatly, but I would like to talk a little bit more to the community piece and some of the funding priorities as well. Some of the other opportunities that we heard are, the fact that we need to make it much clearer that, number one, we almost solely focus on outcomes measures, and we really need to begin to pull in process measures. And in doing that, we need to make a distinction between what's happening in healthcare delivery versus what's happening in all these other inputs. So that would relate to the work within the space of social determinants. So really looking at, number one, what is the health system doing? What does the health system have accountability for? Where are those opportunities to make those outcomes more equitable? But then separately looking at where are the opportunities with all these other inputs where there could be transportation issues, where there could be food disparities, so on and so forth. And so it's really segmenting or separating the two. And then making certain that you have more voices from the community as a part of that conversation. And where this really came into play was, really looking at tailored approaches. So in other words, within the space of equity, we look at our subpopulations, but the reality of it is that think about unpacking this. Are we prepared, to look at what's important to Black patients as it relates to controlling hypertension? And can that be very different from what's important to Latino patients and or what might be important to white patients or any other subgroup that you name? The point of it is that it's clear in the body of research that we've developed is that there may indeed be differences in the approaches that we need to take, because we're hearing differences from these patient populations in terms of what they see as their priorities. And that may also be regionally driven or more locally driven in terms of what those differences might be. And so having these community, the community more tightly integrated into the work is also important as well. And so I'll just leave you with just a few of the additional quotes, if you will, that we've heard from the group. We need to reconsider or make reconsiderations about our funding decisions and who's influencing those funding decisions. We need to foster stronger community engagement and empowerment of diverse participation. What matters is at the most fundamental level in terms of inclusion and diversity, if you're starting at the very front of the research process, we need much greater diversity and inclusion, but it's not just the people don't understand that we need the diversity. We need the mechanisms and the tools that will ensure that inclusion occurs. And so it really gets back to and drives back at this point of accountability and making certain that all the things that we know in the science of equity and that we've learned over the most recent 2 decades, how can we take that and use that as a lens in our approach in patient-centered measurement? And then how do we begin to kind of segment that and unpack that in our work such that we're driving more meaningful change? So with that, Brianna, I will turn it back over to you.
Thank you so much, all. This is fantastic. We already have a handful of questions, but I wanted to just give Ellen an opportunity to jump in and do a quick summary before we go there.
Sure. So I'll keep this really, really brief because I'm eager to hear your questions. What I want to just drive home is that when measurement is patient-centered and equitable, it guides us towards care that's patient-centered and equitable. That's where we're trying to go. Measurement is, one of the tools that we use to guide us in how we do our work, what we're doing, how we get there. And so, in that way, it's our compass. So if we want our compass, if we want to go north, our compass needs to point north. If we want a healthcare system that's patient-centered and equitable, we need our measurement to be the same. So, whatever your role is in measurement, and I'm sure we have much diversity of that in our audience here today, think about what are the opportunities to, partner with a diverse range of patients and caregivers, bring the richness and insights of their lived experience into your work, whether that's at an interpersonal level, building relationships, shifting some of that culture, or maybe you have opportunities to adjust some of those structures and build in the accountability that Knitasha just spoke about. So I'm really looking forward to your questions, and also we'll just offer any one of us is happy to have follow-up conversations after this. So I'll turn it back over to you.
Thank you. Thanks, Ellen. So I think just first things first, a lot of folks on the line here represent different measure development groups or other quality organizations. And I think, Derek, it would be great if you could tell us a little bit more about how you got involved in quality measurement projects and kind of what some of the most important things you learned in the early days that really helped you to contribute most effectively in that space.
Yeah, it's a great question. So basically, when I started to get involved, the first part, of course, as a dialysis patient, we have the QIP from CMS. So, you see those measures, you try to really understand the impact. They're not often talked about as much as they should be with patients and providers because they do drive your care. And so I served on a TEP back in 2014-15. That was my first real engagement in the measurement process. And I quickly realized as a patient advocate that was one of the most meaningful ways for me to get engaged in improving patient care, because it not only, a lot of the things we did at the time would help a group of patients, but this really helped thousands of patients have a better experience or better outcome based on our experiences. I found that it was a bit overwhelming to sit in the room, at many times, you're one or two patients in a room full of people. Everyone else are professionals. But I felt that if I told my story and the more I got comfortable with it, the better the conversation went, and that the physicians and measurement folks that were involved really were interested to hear what the patients had to say. So from there, I chair several patient groups. One is from the National Forum of ESRD Networks. It's the Kidney Patient Advisory Council, KPAC. So we made it one of our goals about 5 years ago to mentor other patients so they didn't feel so overwhelmed, and they felt more comfortable applying. And since 2015, there's a fairly small group of patients, but we've had about 7 patients who have never been involved in a TEP serve on TEPs. It's one of our goals each year to get more and more patients and be involved, especially in the kidney space. But I've been involved outside of that on like the Secretary's Impact Report, wider, broader measures, because for us in the kidney space, unfortunately, we go to a lot of areas where hospitals and care centers and beyond dialysis facilities and transplant centers. So we really have a lot of experience that can help in measures. And I think it's just become really important to me that we're engaged in, and like we said, I'm engaged in a lot of measures around cost, things that are outside of, I guess, what you think your patient experience scope has. But the more I'm involved, the better I understand things, the better feedback I give. And so it's not only just patient outcome report measures. It's I think we can really play a big role in all measurement, because it impacts our care, it drives our care, and the more we understand that, I think the more we can assist in making that measurement meaningful.
Thank you so much, Derek. One of the questions that we got in the chat, I think maybe, Ellen, I'm going to direct this to you, but feel free to punt it back to me. Can you explain why CAPS is not considered a patient-centered measure? This person says that ultimately systems use that data to improve care. Is that something that you think you can speak to?
Yeah. So I wouldn't say point blank that CAPS is not a patient-centered measure. When I raised that earlier, my point is that this idea of patient-centered measurement isn't limited to any one particular type of measure. And so it's not about what you're measuring. So CAPS is trying to measure the patient experience of care, right? And so it is certainly capturing the patient's perspective, and it's asking for data from patients about their experience. But that alone does not mean it's patient-centered, right? So the question is really, first of all, how was that measure developed? What was the role of patients or caregivers, in deciding what to measure, and, how to pull the survey together, and, thinking about, how we make sense of the data, how is the score calculated? So there's that piece of things. And the many existing CAP surveys have been developed, by a range of folks, and it's not always transparent, actually, how that process went. But even once you have a measure, let's just say that there was, full partnership with patients around development of a particular measure, then the question also is, how are you using it, right? So, and that's really a question that gets very, very local. How is any one hospital or health system using the results of their CAP survey to guide their care? Like, are they ultimately getting to a place where the care is improving and it's better for their patients? Is it better for all their patients? You know, are they digging in and looking to understand who isn't being served well by what we're doing and how can we make that better? So there's also an important role for patients in the sort of the interpretation and especially acting on the results of measurement, and that by its nature has to really happen at a local level. You know, so something like a patient family advisory council could certainly provide useful insight, but there are additional opportunities for partnership in how you act on a measure. And so I would really say that no one measure is inherently patient-centered. That's why we talk about patient-centered measurement, because it's really about the whole process of measurement from development to selection, implementation, and ultimately use, that where we need that patient-centeredness, the partnership, and the intentionality around equity to be baked in across that whole measurement cycle.
Thanks, Ellen. Knitasha, the next question is for you. How does the lack of health equity data collection, such as social determinants of health, impact healthcare's ability to assess and improve care for the population, or specifically for populations with known barriers to access and outcome? And follow-up is, how can we push policy to incentivize the data collection of social determinants of health information? And Knitasha, if you're speaking, you're on mute.
Thank you. My apologies. Yeah, there is a huge opportunity for us to start with cleaning up our own house. There's a lot of work that has been underway that needs to be reinforced on another level of accountability, starting with the significant level of effort that is required to improve our race, ethnicity, and language data collections by focusing on the quality of that data, right? So, for example, the attestations that hospitals or I should say health services delivery organizations that report that data, are we actually, do we have a system of accountability that actually goes back to measure the quality of that data? So significant efforts need to be focused on the improvement of that. A national focus also needs to be placed on increasing sponsorship of things like CMS disparities data for use in research. So, like the cost of data is a barrier to much of this research. And so we need to look at how we can improve access to much of the disparities data that exists out here for the use of future research. And then I'd also say some guidance and resources to support payment models that advance the improvement of social determinants of health. And so there's work that we actually started in QF in this space. There's tons of other work that other organizations have been doing. Some funders that have been working in this space, and I think that we need to galvanize those efforts. And then lastly, but certainly not least, and this is probably the one that I'd add to the very top, we simply need to create a national goal on this, right? In other words, so when I was working with CMS with the Partnership for Patients, right, we had a national goal to improve hospital-acquired conditions by 20% or reduce them by 20%. We had a national goal to do the same with readmissions, and I would suggest that when we're really serious about equity, that we create a national goal that will drive improvements in a more equitable way and use similar type metrics. So those are the recommendations that I would make as it relates to data.
Thank you so much. And actually, we have a handful of additional questions that we don't have time to get to since we're at the top of the hour. I will forward those on to our presenters to respond via email. So thank you all for your presentation. Thank everyone who participated today and asked these great questions. Just a heads up, next month we're going to be doing a presentation on patient-reported outcomes. It's going to be a joint presentation between myself and the National Quality Forum, which should be a nice companion to today's presentation. So look forward to seeing more of you there then. And thanks again, everybody. Have a great week.